Hey guys, this summary is for chapter 33, Braunwald's, I think it's 2018 edition, Genetics of Cardiac Arrhythmias. So this is what we will be seeing, and I'll just skim through my notes. The most important things, this is a somewhat long chapter, has a lot of details that aren't not even legitimate as of now, because they're telling us of different potential genetic relationships that haven't even been seen in large studies, because these are very small groups of patients. You will read through this chapter and you will see that there are some sections that will tell you of one specific genetic disorder found in one patient. This isn't, for me right now, important, since there's no validation. So let's go through what is already sort of studied and somewhat validated with larger numbers of patients. So the cardiac channelopathies have the capacity to cause the heart of an unsuspecting individual to develop a potentially lethal arrhythmia. Then these channelopathies are almost 1/3 of autopsy-negative sudden unexplained death syndrome in young persons, and explain up to 10% of sudden infant death syndrome. Okay, why autopsy negative? Because the heart looks structurally normal, but these channelopathies, which will be microscopic, talking about flow of ions or interactions between proteins, will be the real alteration, and will not be able to be assessed through autopsy. Specifically, we focus first on the QTopathies, which will be the long QT syndrome, then Criatin knockout syndrome, Anderson-Tawil syndrome, Timothy syndrome, short QT, drug-induced torsades, early repolarization, idiopathic ventricular fibrillation, progressive cardiac conduction disease, six-sinus syndrome, catecholaminergic polymorphic ventricular tachycardia, anchoring B syndrome, and familial atrial fibrillation. So I'll talk about all of these, but probably some brief points on some, which there's, for example, Timothy syndrome has only 30 cases reported worldwide. So we won't focus that much on that one. Okay, now on to long QT syndrome. It is characterized by delayed repolarization, QT, corrected QT more than 480 milliseconds, as the 50th percentile among individuals with genetically confirmed long QT syndrome. The incidence may exceed 1 in 2,500 persons. It may or may not be manifested on a resting 12-lead EKG. And it is almost always without consequence, but rarely it may be the trigger for a lethal arrhythmia. So that's why we want to check this out. Although most often the episode that may ensue would be a transient episode of syncope, but 5% of these untreated or unsuspecting long QT syndrome individuals succumb. So pay attention to them. Be sure, rule out any risk of sudden cardiac death or sudden cardiac arrest. It is estimated that almost half exhibited prior warning signs. So which signs? Exertional syncope, family history of premature sudden death. Long QT syndrome is approximately 20% of autopsy negative sudden death, unexpected death in young, and 10% of SIDS, which would be sudden infant death syndrome. Genetic basis. So Mostly it is autosomal dominant. It is what was known as Romano-Ward syndrome. How do I associate this one with autosomal dominant? Because Romano makes me remember of the Romans. They were dominant, autosomal dominant, and rarely recessive, which would be Gerbil and Lange-Nielsen. These guys had sensory neural hearing loss, and it produced a more severe cardiac phenotype. Then we have that there's 14 long QT syndrome susceptibility genes responsible for a non-syndromic classic long QT syndrome phenotype. But we have two of these that are two extremely rare cases which would affect multiple systems, which would be the Timothy syndrome and Anderson-Tawil, as well as long QT type 4, which would be better known as Anchorian B syndrome. We'll mention this later on. Approximately 75% long QT syndrome host either loss of function or gain of function mutations in one of three major genes, which are the most important genes in descending fashion: KCNQ1, which would be a potassium channel, would be 35% of cases associated with loss of function. KCNH2, also a potassium channel associated with loss of function, 30% of cases. And the one that's different is SCN5A, which is a sodium channel and would represent 10% and is associated with a gain of function. So this one would be sodium and gain of function. 5 to 10% of the individuals with multi-mutations usually will present a more severe phenotype and younger age at presentation. In red, you can see the genes involved and the channel that is affected. We already mentioned this. We'll talk about all of these later on. So let's look at this figure. It says it shows us the main ion channels that are affected in long QT syndrome. It is the same thing I just mentioned, only that this is in an illustration, which would be better probably to remember. So we can see which genes are affected. The ones that are most affected, remember there are three. Here we have number 1, number 2, and number 3. And we also have this one, which is also implicated, which is CAX-NAC, and these other two. So in blue, you will see loss of function. And in red, you will see, shown in green, gain of function. In blue, loss of function. So this one is interesting. For example, how SCN5A, loss of function, this one leads to Brugada syndrome, and gain of function leads to long QT syndrome type. This is we'll see it next. So what else can we see here? Sick sinus syndrome is around here, SSS right here, which would be a loss of function. Okay, and we also see Brugada, we already mentioned it. We see cardiac conduction disorder. Where is it? It's right here, also loss of function. So this is one of the most popular ones. So 3 to 5% of genetically elusive long QT syndrome may be attributed to CAC-NA1C, I just mentioned it, mutations, making it potentially the 5th most common genetic substrate for non-syndromic LQT syndrome. Calmodulin positive LQT syndrome patients exhibit the common cardiac features of life-threatening ventricular arrhythmias occurring very early in life, frequent T-wave alternance, greatly prolonged QT intervals, more than 600 milliseconds, that's too much. And intermittent 2 to 1 atrioventricular block, 3 of 4 patients. So we can see the small numbers of patients, and obviously there will be small numbers because these syndromes are very, or mutations are very infrequent. In 2017, it is important to note that almost 20% of clinically definite cases of LQT syndrome remain genetically elusive. So 20%. It's somewhat, but not that much. In long QT, you can find out 75 to 80%. This is different to Brugada, which we will see that you identify just 25%. Here you can see in this figure probabilistic nature. So let's look at this. Radical mutations. Any mutation that is radical, and which ones would be radical? Frame shift. This means that all your genetic transcript has moved, so everything will get screwed from there on. Insertion or deletions. Well, you put a nucleotide where and an amino acid, no, a base where it shouldn't be, so you might change what is transcribed. Nonsense would be stopping that from would make a stop codon. So if you make a stop codon, you stop it right there. You usually make a non-functional protein or truncated protein. Splice site mutation usually will make problems with exons and introns and malfunctioning protein. So all these mutations will create havoc. Here we can see in the red circles the ones that 3 major ion channels causative of LQT syndrome, with areas of probability of pathogenicity shown. So here we can see number 1, number 2, and number 3. The 3 of them in long QT syndrome are ion channels, transmembrane ion channels. So there's also mutations in other sections, but they aren't that important. Now let's go on to talk about this figure, which is the correlation between genotype and phenotype in long QT syndrome. So first, here we have the most frequent once again, and what we are seeing in this image is what triggers the syndrome. So here we have swimming, exertion, and emotion in KCNQ1. Here in this one, KCNH2, we have auditory triggers or postpartum period, and in LQT type 3, the sodium channel affected, and this one usually happens during sleep or rest. This is similar to Brugada and presentation, for example. So nothing of that is very important. And here what you can see is illustrated is the proposed microRNA mediated allele specific KCNQ1 gene transcript suppressing mechanism, supported by the existence of naturally occurring SNPs within the KCNQ1-3 untranslated region. Well, what does this mean? That here phenotype is more severe because the QT is more affected. And why is the QT more affected? Because you have more affected, more mutations added. The blue would be mutations, yellow would be normal allele. What about this other syndrome, triadin knockout syndrome? Almost 15% of their genetically elusive long QT syndrome cohort overall, and 50% of the children less or equal to 10 years with genetically elusive long QT syndrome hosted homozygous or compound heterozygous TRDN frameshift mutations, which TRDN is of triadin knockout syndrome. Patients often presented with sudden cardiac arrest before age 5, and current therapeutic strategies, beta blockers and left cardiac sympathetic denervation surgery, have not been effective. The parents of these children, who are all heterozygous for a triadenine null allele, do not have an overt abnormal cardiac phenotype. TRDN mutations have been implicated previously in recessively inherited cathecholaminergic polymorphic ventricular tachycardia, as identified in 2 of 97 patients diagnosed with CPVT who were genotype negative for RYR or CASQ2 mutations. Specifically, cardiac creatinine is responsible for stabilization of the T-tubule junctional sarcoplasmic reticulum associated by Lincoln. Now, Anderson-Tawil syndrome. It was first described in 1971. It is rare, a multi-system disorder characterized by a triad of clinical features. Which ones? Periodic paralysis, dysmorphic features, and ventricular arrhythmias. Although ventricular ectopy is common, majority of ATS patients are asymptomatic, and sudden cardiac death is extremely rare. It was initially proposed as type 7 lung QT syndrome, correctly distinguishing between ATS, Anderson-Tawil, and a catecholaminergic polymorphism is critical because the treatment strategies are quite different. Now going on to Timothy syndrome, clinical description and manifestations. This is also known as long QT type 8, extremely rare, less than 30 patients described worldwide. Extracardiac abnormalities often consist of simple syndactyly or webbing of toes and fingers, dysmorphic facial features, abnormal dentition, immune deficiency, severe hypoglycemia, and developmental delay, or including autism. Now, short QT syndrome. This was described first in 2000, associated with less or equal to 320 milliseconds on a 12 lead, paroxysmal atrial fibrillation, syncope, and increased risk for sudden cardiac death are different forms of presentation. Remember, in this one, in short QT syndrome, different from long QT syndrome, most patients were symptomatic, 62%, with cardiac arrest being the most common symptom in 31% of the patients, 1/3 presented with cardiac arrest. Autosomal dominant manner, mainly 6 genes are involved. Here you can see basically the same genes involved in long QT syndrome. Here you have KCNH2, KCNQ1, KCNJ2, loss of function, mutations, CAC, and all that. More than 75% of SQT, short QT, remain elusive genetically. So this is similar to Brugada. 75% remain elusive genetically. Insufficient data exist to define genotype-phenotype correlations clearly in short QT syndrome, since probably less than 60%, 60 cases have been described in the literature to date. That's nothing. 320 milliseconds or less, QT corrected less or equal to 340 milliseconds, and tall peak T waves in the precordial. Then we have drug-induced torsades. Incidence of antiarrhythmic drug-induced torsades has ranged from 1 to 8% depending on the drug and dose. IQR channel blockers. Okay, so associate these torsades induced by meds with this channel, the IQR channel, also referred to as the HERG channel blockers. What they say is that you won't have an arrhythmia just by using the medication alone without having another hit. So this talks about the 2-hit probably hypothesis, and based on that, this leads us to the repolarization reserve, which means that there is some sort of safe space before arrhythmia ensuing. So the repolarization reserve may be reduced through anomalies in the repolarization machinery. And um, this alteration plus a medication which induces arrhythmias or long QT makes it worse. Okay, now in fact K897T appears to affect the QT-C response to butylite in a gender-specific manner. Nothing special there. Hypothesized that genetic variants in NOS1AP, this is not nitric oxide synthase, that suppress the gene's expression may in turn result in increased LTCC currents and subsequent QT prolongation, and such individuals may be at increased arrhythmogenic risk while taking amiodarone. Now, the other channelopathies. Catecholinergic polymorphic ventricular tachycardia, heritable arrhythmia syndrome that classically manifests with exercise-induced syncope or sudden death, is predominantly expressed in young persons and closely mimics the phenotype byline of long QT type 1, but appears to be much more lethal. Swimming is a potentially lethal arrhythmia precipitating trigger in CPVT. CPVT is associated with a completely normal resting EKG, perhaps bradycardia and mild U waves, and this is suspected on EKG after exercise or catecholamine stress testing and demonstrates significant ventricular ectopy, occasionally with CPVTs, pathognomonic arrhythmia, or bidirectional ventricular tachycardia. Exercise-induced syncope and QTC less than 460 prompts first consideration and need to rule out CPVT. Premature ventricular complexes in bigeminy is more common, more likely than the more specific bidirectional ventricular tachycardia. Lethality rates of 30 to 50% by age 35 and presence of a positive family history of young, less than 40 years, sudden cardiac death for more than 1/3. RYR2 mutations, 15% of autopsy negative sudden unexpected death in young persons and some cases of SIDS. So this one is associated with the ryanodine channel. It's associated with an autosomal dominant mutation in the RYR encoded cardiac ryanodine receptor calcium release channel. 60% of clinically strong cases of CPVT have this. So here we can see the RYR2 channel, and let's see, calcium-induced calcium release mechanism responsible for cardiac excitation, contraction coupling is the pathogenic basis for CPVT. RYR2 encoded cardiac ryanodine receptor release. Greater than 90% of RYR2 mutations discovered to date represent missense mutations. Recently, mutations in COM1 and COM3 have been implicated as a cause of autosomal dominant. So it's associated with the mutation of RYR, also of COM1 and 2. Now let's go on to talk of Brugada syndrome. Brugada syndrome, the curved type ST segment elevation more equal to 2 millimeters, followed by a negative T wave in the right precordial leads V1 through V3, often referred to as type 1 Brugada EKG pattern, and an increased risk for SCD resulting from episodes of polymorphic ventricular tachycardia. Penetrance and expressivity is highly variable. It is greatest amongst Southeast Asian men with arrhythmogenic manifestation, first average age of 40 years. Genetic basis, autosomal dominant, although more than half of Brugada syndrome cases may be sporadic. Approximately 20 to 30% result from loss of function mutations in the SCN5A. Patients hosting multiple SCN5A mutations tend to be younger at diagnosis, 29 years old, than those with a single mutation, 39 years old. The most common BRS1 mutation also been reported as the most frequent, seeing LQT3 associated SCN5A mutation, illustrating how the same DNA alteration, here it's loss of function, in a given gene can lead to two distinct cardiac arrhythmias syndromes, most likely as a result of other environmental or genetic modifying factors. To date, 18 genes have been implicated, but only SCN5A shows a significant contribution. In fact, extreme caution must be used when interpreting rare genetic variants identified within the minor BRS genes. Importantly, the genetic cause of more than two-thirds of clinically diagnosed BRS remains elusive, suggesting a high degree of genetic heterogeneity. Unlike long-QT genetic testing, in which the triad of diagnostic, prognostic, and therapeutic impact has been fulfilled, Brugada genetic testing is currently limited to its lower yield, 25% versus 75% for long-QT, and relative absence of a therapeutic contribution from knowing the genotype. Now, early repolarization syndrome. It's an elevation of more or equal to 1 millimeter above baseline of the QRS TDJ point. It's manifesting as QRS slurring at transition of QRS to ST segment, or notching, which would be positive deflection inscribed on terminal S wave, ST segment elevation with upper concavity, and prominent T waves in two or more contiguous leads. The prevalence is 1 to 13%, depending on age, sex, race, and criteria for J-point elevation. The clinical conundrum with respect to this inferolateral ERS, early repolarization syndrome, is distinguishing the potentially lethal ERS from the frequently observed juvenile ER pattern seen in healthy adults, healthy individuals, particularly athletes. They still don't know how to differentiate them. However, not all these genetic variants have been characterized functionally, and some may represent rare variants of uncertain significance. In addition, rare variants in ABC, SCN, and ACN have been implicated in ERS. Now, idiopathic ventricular fibrillation. In essence, as in SIDS, IVF is a diagnosis of exclusion and can stem from several underlying mechanisms, up to 10% of sudden deaths, especially in younger population. About 30% of IVF labeled individuals will have recurrent episodes. About 20% have a family history of sudden death or IVF, suggesting a hereditary component. For most IVF cases, a genetic mechanism remains undefined. Now, progressive cardiac conduction disease. Progressive or age-related alteration of impulse propagation through the His-Purkinje system with right or left bundle branch block and widening of the QRS complex, leading to complete AV block, syncope, and occasionally sudden death. Data suggest that mutations with a more deleterious loss of sodium current produce a more severe phenotype of syncope and conduction defect, providing the first evidence of intragenotype risk stratification associated with SCN5A loss of function disease. Now, sick sinus syndrome, or sick node dysfunction. It's inappropriate sinus brady, sinus arrest, atrial standstill, tachycardia, bradycardia syndrome, or chronotropic incompetence. It is the leading reason for pacemaker implantation and has been attributed to dysfunction of the sinoatrial node. 1 in 600 cardiac patients over the age of 65. Okay, ahora, ankyrin B syndrome. Anchoring B protein is a member of a large family of proteins that anchors various integral membrane proteins to the spectrin-based cytoskeleton, anchoring the sodium-potassium ATPase, sodium-calcium exchanger, and INS-P3 receptor. 2% to 4% of ostensibly healthy white controls and 8 to 10% of black controls also host rare variants in ANC2, underscoring the challenge in distinguishing pathogenic from rare ANK2 variants of uncertain significance. Now, familial atrial fibrillation. AFib is the most common cardiac arrhythmia with a prevalence of about 1% in the general population and 6% in people over 65. It is responsible for more than one-third of cardioembolic episodes. Approximately one-third of lone AF patients have a family history of AF, suggesting familial forms of the disease. Beside these potassium channels, Na1.5, sodium 1.5 has been implicated in lone and familial AF. In fact, AF is a fairly common arrhythmia among patients with loss of function SCN5A-opathies. In particular, up to 15% to 20% of BRS, Brugada syndrome cases develop AFib. Future perspectives: young discipline of the heritable arrhythmia syndromes and cardiac channelopathies has been exploded over the past decade. Next generation sequencing platforms and systems biology bioinformatics algorithms are providing new tools to efficiently interrogate an individual's entire genome or exome. Current and forthcoming advanced sequencing will soon allow us to close the genetic gap in our understanding of those potentially lethal yet highly treatable cardiac arrhythmia syndrome. This will not only foster new disease-causing gene discovery, but also reveal novel genetic variants that may be in part explain reduced penetrance and variable expressivity and help identify patients at greater risk of a potential tragic cardiac event. Despite the pharmacologic and invasive therapies for inherited cardiac arrhythmia disorders from often achieve symptom reduction, there is still an urgent need for alternative therapeutics to effectively treat or even cure the most severe forms. With continued understanding of genetic and molecular basis, genetic silencing, RNA-guided nuclease-mediated CRISPR, Cas9 genome editing, sophisticated viral vectors, gene therapy may become a feasible option for some patients with difficult to manage, potentially life-threatening cardiac arrhythmias. That's it. Very sleepy, but that's it. We got it. So,